Hi, everybody. We're going to get started now. So my name is Annie Thomas-Diceman, and I'm a social worker at St. Michael's Hospital in Toronto, and I'm one of the co-moderators today, and my colleague Lisa will come up and introduce herself when she comes up to speak. So just to start off, I'm going to start off with my pre-prepared little speech here. So good morning and welcome. We're so glad to see so many people here. I know that it's early morning on a Saturday, nearing the end of the conference after not a whole lot of sleep, so we appreciate the people that are able to make it out here. So today we're gathering to talk about a very important topic, aging with grace and cystic fibrosis. So with advancements in treatment, we know people are living longer, and they're living fuller lives than ever before. This presents new opportunities and also new challenges, especially as we look at what it means to age with a chronic condition like CF. So today's session will cover a range of perspectives from the medical complexities of aging with CF to managing the cognitive and emotional health to navigating the practical aspects like financial planning and life milestones, just to name a few. Each of our speakers will dive a little bit deeper into these areas, and we hope that you'll walk away with perhaps one or two new insights and hope that you'll feel empowered to handle these challenges. So let's get started. So I'm going to first introduce our first speaker is Dr. Ann Stevenson. She is a respirologist or pulmonologist, as you would refer to in the States. She works at St. Michael's Hospital in Toronto in our clinic, and she is also the Canadian Director of the CF Registry. Welcome, Ann.
Excellent. Okay. Thanks, Annie, and thanks to the moderators for inviting me to speak today. So I'm going to talk about getting older with cystic fibrosis. These are my disclosures. So I'm going to first talk a little bit about the evolving CF landscape, mention some of the complications, although I'm going to go into a bit more detail later this morning at another talk on aging in those complications, and then how aging might impact the model of care, and discuss briefly about the role of a primary care provider or physician, nurse, a practitioner in CF care. So evolving CF landscape. This is a quote from one of the mothers who had a child with cystic fibrosis that I know quite well. And she said, in 1970, my daughter was born. We were told that there was a 50% chance she would die before the age of 14. But today, parents are told in 2022 that parents of children born with CF are told that they have a 50% chance that their child will live beyond 60 years of age. So obviously that is a huge difference in terms of planning for the future and expectations for the future. But what is old depends on who is asking the question. This is a picture of my daughter when she was young, and for her, being old was probably somebody who was 15 or 20 years of age. And when she got to be 20, what was old for her was probably somebody who was maybe in their 50s. And I will tell you, I am not old, okay? I'm constantly telling my kids, I am so young. And what I think is old is probably someone more like this Apple doll that, you know, is looking extremely old. So it really depends on who's asking the question. But we know that there's increasing number of quote unquote older adults, and this is from the Canadian CF Registry report, where 66% of the Canadian population is over the age of 18, and that's been increasing over the years. And increasing number of individuals living into really older ages, not just over the age of 18, but this is a graph again from the Canadian Registry report showing age on the x-axis, and on the left-hand side, number of individuals with cystic fibrosis, and each blue bar represents people at certain ages. And you can see from this graph that, you know, people are living into their 40s, 50s, 60s, and 70s with cystic fibrosis. So the adult population is sort of unique in the sense that it's becoming more and more diverse. The pediatric population, once they hit 18, that's a hard stop. They move over to the adult clinic. But at the adult clinic, we look after people, wide range of ages. We have people who are, some of which are eligible for ETI or modulator therapy, some of them are not. We look after pre and post-transplant patients. And we see a wider spectrum of complications and comorbidities in our patients, and we have patients of increasing racial diversity. And we know that there are many classic complications associated with CF, and none of these are really new to this group. But what is different is how long you're living with these complications. So CF-related diabetes is a perfect example because we know that people have diabetes, but if they die at earlier ages, they may not experience the complications associated with diabetes that other people in other diseases experience. So for example, retinopathy, nephropathy, peripheral neuropathy, cardiovascular disease, like micro and macrovascular disease. So living longer with these classic complications that we know a lot about raises new issues as well. But there are emerging and unanticipated complications that we need to start thinking about. And the classic one is on this slide, there's lots of them, but think of obesity. 20 years ago when I started doing cystic fibrosis, obesity really wasn't a thing. We know that even pre-modulators, people were starting to gain more weight, and now with ETI, people are experiencing even more weight gain. And that is increasing the risk of other complications. For example, sleep problems. So we looked at some of the data from our clinic showing that people who had sleep studies, there was a high proportion of people who had obstructive sleep apnea. And so as weight goes up, that might become more of an issue. But again, it's not really something that I've been dealing with a lot over the last 20 years. Cardiac disease, obesity is a risk factor for cardiac disease, hypertension, micro and macrovascular disease. All of these things are sort of interconnected. And I will just say that at the Aging and CF Symposium that is happening later on this morning, I'm going to be talking a little bit more about some of the risks associated with those complications. So I'm not going to go into that in a lot of detail right now. So the impact of modulators, what is that doing to aging? This is a study that was published in 2023 looking at the rate of decline in lung function with ETI, so elexacaftor, tezacaftor, ivacaftor. And we know that there's a bump up of lung function when patients get on this medication often. But what happens to the trajectory of lung function over time? And this is a study showing basically after that bump up in lung function, which is seen on the left-hand side, the light blue line shows over the next 2 years, what's the trajectory of FEV1 in these patients on the medication compared to a control group, which is in the dark blue line. And you can see that as time goes on, the gap between those two lines gets wider, suggesting that the people who are on ETI have a fairly stable lung function over time, whereas the control group has a decreasing lung function. So as people age, we can expect that their lung function may decrease naturally, but if they're on this drug, it looks like over the short term anyway, it's not decreasing very, very quickly. And we know that one of the best predictors of survival is lung function. So if lung function doesn't decrease in the same way, that people are going to live even longer. And this is another study that was published with a slightly longer time window. This is looking again at people who were prescribed randomized to drug, which is the blue line, and placebo in the gray line. And then it was an open label trial where people who were on placebo then changed over to go on to drug. And you can see that over 144 weeks, so 3 years, lung function was maintained and stable on the medication. So again, suggesting, I'm not saying that ETI is going to make it such that our lung function will never decrease, because even with normal aging, our lung function does decrease over time. But in this time window, it looks that lung function is not decreasing as we have seen in the past. So again, people are going to live longer for sure, because this lung function is very closely related to survival. And speaking of survival, survival's been increasing even prior to the availability of ETI and other modulators. And this is a graph, again, from the Canadian CF Registry report, but lots of countries have similar experiences where survival has been increasing, median age of survival on the y-axis and time on the x-axis, and we see that it's been increasing. And as I mentioned, with lung function being relatively stable, we expect that survival is going to increase even further in the future. But what can we expect in the future? And this was a study that we were involved in. It was a simulation study where we took the Canadian CF Registry data and we did sort of an experiment where we said everybody who had a delta F508 mutation was eligible for the medication. We simulated that everybody who got the medication had on average an increase in lung function of about 14% and a 63% reduction in pulmonary exacerbations, because that was based on the clinical trials that we knew those results. We also said, okay, let's assume that people are going to have a reduction in the lung function decline. Now, I just showed you a couple of studies that showed there was virtually no decrease in lung function over time. But when we did this study, those weren't published. So we used the data from ivacaftor, the ivacaftor post-marketing studies, which showed that there was a 50% decline in lung function, or a 50% reduction in the decline in lung function. So we sort of applied that to the Canadian population. And then we looked out to 2030 to see what the population would look like. And this is a survival curve that shows, and part of this was because we didn't have ETI in Canada at the time, and we were trying to show delayed access would impact our patients fairly significantly in terms of survival. So we said, what if the drug was available in 2021, or if it was delayed until 2025? And overall, we saw that the population, if they got access to the medication, would increase by about 25%, and that was driven primarily by the adult population. And furthermore, we saw that if there was no availability to the drug, that's the left-hand side light gray line, compared to that line, if we had the medication, survival would increase significantly, and if we had it sooner, it would have a bigger benefit in terms of survival. In fact, median survival was 9 years higher with ETI availability if it was available in 2021. So, and we're not sure exactly what's going to happen if ETI is started even earlier, but we can anticipate, as I'm sure many of you have heard in the conference, that if people are started on this medication earlier on in life, they may not develop some of the CF complications, or some of the complications that they have may be attenuated, or resolution of some of those complications. So the future older CF population will probably look quite different to those that are started on the medication in adulthood. So we can expect that they will develop some comorbidities associated with aging, just the general population associated with aging, the usual complications of getting older. But we have to sort of see what's going to happen with the complications related to CF. In terms of our model of care, obviously that's changing as well. The frequency and types of visits that we're going to have for our CF patients, the types of testing and screening that we're going to be doing, therapies that we're going to be offering, or whether people are going to be doing certain therapies, and the different transitions in our CF population in the life of a patient with CF is going to change probably too, because as they're getting older, the older population is going to have different needs than, say, the young adult population. So there may be geriatric issues that arise, and of course then end of life. Our current model of care, though, is based on the picture that we know of CF in recent decades, and that picture has changed over the years. So now we have to think about new phenotypes and risks and what that means to our new model of care. As I mentioned before, obesity, CF-related diabetes, hypertension, those are all risk factors for cardiovascular disease. So in the future, maybe we're going to have to be screening for cardiovascular disease, or we're going to have to think about that when someone comes to clinic with chest pain, instead of sort of going immediately to, oh, that could be mucus plugging. We have to think, could this actually be a cardiac issue? And the role for primary care, I think, is going to be very important as well. And, people with CF often see us, as you all know, as their primary care provider. And there have been studies that have shown that many people with cystic fibrosis don't have a family doctor, or if they do have a primary care provider, they don't see them as often as they see us. And there's a strong preference to actually going to your CF team for even non-CF issues. And I can't tell you, every week it seems like I'm dealing with things that have nothing to do with CF and have nothing to do with the lungs, which as a respirologist is kind of a bit of an issue. But it is happening more and more that these other issues are coming up in clinic. And I think having a primary care provider is going to become more and more important. And what are the barriers to having a primary care provider? Obviously, the availability of doctors who or nurse practitioners who are providing that care. If there's a decrease in the number of those providers, that's one thing. But if you have access to a primary care provider, what are the issues that people are facing? And from a patient perspective, I think they often feel that when they go to the primary care provider, they have to tell them kind of what they need. I need ciprofloxacin, or I need this dose, not the lower dose, I need a higher dose. So there's a lack of trust and in knowledge between CF patients sometimes and primary care providers. And from the primary care provider perspective, there's a lack of comfort with the disease. They sort of think, they don't know a lot about CF. The CF team can help the patients probably more, and there's a lack of a defined role for primary care providers. So I think there's a discomfort on both sides to discuss CF issues with primary care providers, but I think in the future that's going to have to change. And this is a study that was published in 2020, which was from a large adult clinic, and they reviewed patient charts. And again, they sort of found that almost 60% of people had no identified primary care provider, or they listed their CF physician or team as their primary care provider in the chart. And this graphic shows basically the percent of patients meeting screening recommendations for a variety of things. And you can see that this had to be documented in the chart, but it was documented for things that we're used to dealing with: osteoporosis, depression, diabetes, smoking cessation, alcohol use. Those things were not too bad. But some of the other primary care prevention things like cervical cancer screening, vaccinations, those weren't documented as well in the chart. And it's not clear whether or not these were being provided to the patients. So I think, there are complex needs of older adults with CF. I think there's going to be increased life pressures. Social work is becoming much more important in dealing with some of these life pressures. We're going to have to be screening for more complications that we haven't really been thinking about in the past. I think that there's also a role for education, both with the CF community and also with primary care and specialists. Specialists, particularly, cardiologists, nephrologists, these types of patients who haven't necessarily seen a lot of CF patients and might not feel comfortable dealing with CF patients. I think we're going to have to really educate people and bring them into the circle of care, the multidisciplinary care. And recognize there could be sociocultural differences among our aging population and really address those as well. And working with patients themselves to prepare for old age and what are the expectations, because I think some people are having challenges with not expecting to live as long and having some difficulties emotionally with not planning for that, not having things like, RSPs for retirement, things like that, causing more mental health issues for those patients. So in conclusion, the CF landscape is changing, as we all know. Living with CF in older age is increasing in complexity. And this is a bit of uncharted territory. Most of what we know about dealing with some of these complications is based on pre-ETI data. And we need to think more broadly about complications and how they impact all sorts of aspects of health. And with that, I will end, and I'm happy to take any questions.
I neglected to say at the beginning, there is the Q&A app if anyone wants to put questions in there, but there's also a microphone at the front, or you can call from the back because it's such a small room.
Exactly. Yeah, that's a great question. And it is difficult because the primary care providers are sort of spread out all over the place. So it is difficult. We've sort of taken an approach for specialists, not so much the primary care physicians, but the specialists at our center to really sort of identify a GI doctor or an endocrinologist or a nephrologist that we've sort of approached and said, would you be willing to take on some of these patients and really educate them specifically? And when you have that, that's a lot easier because you know that you can refer your patients to those individuals and they will get education, as time goes on. Primary care is a bit more difficult, and what we struggle with too is sometimes people just don't have a primary care physician and it's hard to get one. And so we sort of go to different resources where they can look and see who's taking on new patients. But again, from an education point of view, it is difficult because you're not going to go to all of the individual family practice units to educate people. I mean, obviously that's not reasonable. But we have to think about other opportunities to really get it out there, either through websites or, speaking to a larger primary practice unit to really sort of advocate for our patients that they need to have primary care. Yeah. Thanks for that. Yeah. It's interesting just to hear other people's experience, especially for engaging other specialists or primary care physicians.
Thank you, Anne.
You're welcome. Thank you.
Excellent.
All right. Well, again, thank you everybody for being here. I'm Lisa Scher. I'm a psychiatrist who is embedded in our adult CF center at Stanford, and I've been working with our CF team for 10 years, and I think really closely embedded for probably 7 or 8 out of those. And I had a kind of recorded presentation earlier, but I also actually consult and work very closely with our lung transplant patients as well, whether CF or not. So I sort of really have a perspective on that kind of domain of the experience. And today I'll be talking to you about, mental health and cognitive challenges as our people with CF are getting older and aging. And again, kind of aging, with sort of, a very, abstract, I think, definition at this point for our patients. I do have a grant from the CF Foundation as part of the CF-CBT implementation grant. All right. So let's just think about just the mental health and cognitive challenges that come up really for, everybody, right? And particularly kind of thinking about people with CF. There is, of course, we'll be talking about depression, anxiety, which are very common in general population, right? So the expectation is that those will not go away because they're not going away in general population. The concept of survivorship, some of the review that I've done for this is sort of like this kind of really thinking about it, survivorship as actually in cancer, that's a concept that is widely applied. Post-traumatic stress disorder, but also post-traumatic growth, changing existential concerns, body image issues, substance use disorders. We will be talking more and more about those because this is what's relevant to general population. This is what the mental health challenges and pretty much, that our society confronts with. And then cognitive concerns and dementias, right, as our people continue to be older and older. And I'll touch on some of them, then definitely happy to discuss. Of course, part of it is that it's not here is ADHD, right? ADHD is also more common with people in CF. And we will see as the kids and adolescents get an ETI, so whether that changes the rates of ADHD in people with CF. But that's also another concern as well and challenge. Of course, I have to reference the TIDE study, right? We do know that people with CF kind of baseline, and of course, this was done before the CFTR modulators, but at baseline, there are 2 to 3 times increased rates of depression and anxiety in people with CF, right, as compared to general population. And we do know that they do worsen the physical outcomes. Of course, they influence quality of life, they worsen physical outcomes, and they also increase mortality. And this is actually, that fact I want to stress is not unique to cystic fibrosis. That is true for other medically affected populations. We know that, for example, if somebody after heart attack has depression, they're more likely to to die sooner, right? Or post-stroke depression also predicts mortality. So that relationship actually has been seen in other medically affected populations as well. And now, we have, ETI and other CFTR modulators, and we've been hearing about the concerns of depression, anxiety, cognitive changes, and worsened sleep, at least in some subset of the patients. And I think, we're still going to be learning more and more about this. And there are definitely studies that have, shown and demonstrated that some people kind of do potentially, they report and do get maybe worse anxiety and sleep and maybe depression. And also a more recent review actually that looks at many of the studies as well as the post-marketing reports coming from US and Germany and evaluated over 60,000 of patients who initiated ETI, noted that there was not actually demonstrated elevated rates of depression overall, right? It's still high. And, remember, right, that depression is a chronic condition. If somebody has a major depressive episode once, they actually risk 50% risk that they will have it at some point again, especially if it's not treated. If they've had it twice, 75%, 3 times, 90%. It's a chronic condition, right? So, I think, we also kind of need to think about it, like what are our expectations in terms of this, right? But I think the interesting thing is that whether we think that CFTR modulators are maybe worsening anxiety or depression and sleep on some patients or not, it's not decreasing depression and anxiety, right? And that's very important, that we will continue to see increased depression and anxiety, and it will continue to affect the quality of life, the functioning, and also depression and anxiety will continue to affect physical outcomes. So that's definitely, as our people live longer with CF, mental health will continue to be, kind of a big part of what we're managing. So psychiatrists in CF are not going to be extinct, selfishly for me, right? Again, right, they're common chronic conditions, right? They're very prevalent in general population. But we do know, right, for example, if they look at depression and anxiety in general population and compare that, let's say, in PCP clinics, right? In PCP clinics, it will be increased. In specialized clinics, it's going to be even more increased. So again, there's data from other medically affected populations that depression and anxiety will continue to be the concerns. And also, I think we're going to actually become more granular in how we define it, right? Because obviously, we talk about depression. But depression, there's a major depressive disorder, there's bipolar disorder, right? And they're treated very differently. Anxiety, there are a variety of anxiety disorders, generalist anxiety disorders, phobias, right? I think we talk about kind of phobias also in CF, right? And understandably, right? Needle draws and treatments. OCD. I've had quite a few patients in my practice, right, who actually struggle with OCD, which also, we sort of use the same medications, like the same toolbox, but in terms of therapies, they're actually different types of therapies, right? For OCD, there's a very particular type of CBT therapy, exposure response prevention, right? So we will be talking about more granular anxiety and depression disorders as well as treatments. And again, just highlighting that it does not seem that the rates are increasing as of yet. And also depression, anxiety, ebb and flow, right? So it also depends, right, when we screen our patients, right? They might do better, and then another trigger comes in, and the patients might struggle more. And there are changing medical concerns and needs, psychosocial demands, and ongoing uncertainty. Things definitely are looking much better, but there's still a lot of ongoing uncertainty, especially with adults that we're seeing right now who started their treatments. Survivorship. So some of the review articles, and I really appreciate that, kind of started thinking about applying the concept of survivorship in CF, right? As early mortality becomes much less certain and sort of delayed, there's kind of analogy to cancer survivorship. And cancer survivorship, they define it as the period between the end of treatment and then end of life, right? When patients go into remission. And of course, it's not that our patients with CF no longer need any treatments, but definitely the intensity of treatment has changed, right? The relationship with CF has changed. So maybe also how we think about it and mental health and existential concerns is also changing. But when we look at the literature in cancer survivorship, the quality of life is still affected even after patients have undergone treatment, cancer's in remission, but they still are dealing with kind of what has happened earlier, right? With that notion of mortality. They're dealing with potential complications of their treatment. So that kind of experience, right, as really any traumatic experience, still lives on, right? And we will be, I think, seeing and studying more and more within CF as well. And at least early on in cancer survivorship, depression, anxiety, and even suicidal ideation actually increased, right? So it will be also interesting to see, right, kind of as our patients with CF now on ETIs, and of course those who are not, fully processing, right, and seeing the new reality, we will be seeing some, different concerns. And in cancer patients, the risk factors for increased depression, anxiety, and suicidal ideation are younger age, right? And our patients are younger, as well as previous psychiatric diagnosis, not surprising. And again, our patients with CF are already at increased risk, or history of substance use. So let's shift to talk about post-traumatic stress disorder. In the psychiatric Bible, right, DSM, or Diagnostical Statistical Manual, post-traumatic stress disorder used to be classified as an anxiety disorder, but not as actually a trauma-associated disorder. But there's a lot of features of, of course, anxiety. And what is PTSD? PTSD is when somebody is they're threatened, their mortality has been threatened. Either assault, natural disaster, a war, or actually medical situation, right? For example, we know that PTSD is just as common in ICU survivors as it is in somebody who survived a natural disaster, right? And we know that, patients who deal with medical illness also are at higher rates of PTSD. So there are only a few studies maybe that have been done at CF, kind of really looking at that. But there is one study where they looked at over 200 adolescents and young adults with chronic illnesses. Only 14 of them had CF, and others had diabetes type 1 and juvenile idiopathic arthritis. But it's interesting that more than a third of those patients did report relevant post-traumatic stress symptoms. And they were associated, again, with depression and anxiety, and had an effect on their overall health as well. So that'll be also interesting. That's something we will be looking at more and more, kind of really understanding sort of the PTSD symptoms and how they affect our patients. Another population that's different, but kind of relevant, right, is actually looking at transplant patients. I mean, I always think about transplant patients because that's my other population, right? But for example, we do know that transplant recipients, including lung transplant recipients, they do have high rates of PTSD. And again, it's 10 to 15%, which is, again, similar to somebody who has gone through a trauma, right, in any other situation, war, combat, right, natural disaster. So that's pretty incredible, right? And for example, in our transplant patients, what we see is that, usually the symptoms of PTSD are sort of like intrusive thoughts, right? All of a sudden you just think about this traumatic experience. And of course, you think about our people with CF growing up, right? There are multiple kind of micro traumatic experiences, right? Thinking about, right, just thinking about mortality, or maybe growing up with CF, all those needle draws, right? All the PFTs, all the treatments, or being hospitalized, right? There's multiple those encounters. And again, so in PTSD, you have those intrusive thoughts, you might have nightmares, you're hypervigilant, right, kind of on edge, right? You always think there might be danger somewhere, right? And again, if you continue to live with a medical condition, there is, right? There's ongoing danger. And avoidance symptoms, right? Really trying to avoid whatever reminded you of the trauma. So for example, in transplant recipients, the re-experiencing and arousal are more common than avoidance symptoms, right? Because of course, rationally, patients understand that, well, they cannot really avoid the clinic or the hospital, but some do. Right? And we know patients who are not coming to our clinics because it's just so traumatizing to even maybe have some conversation. So I think some additional focus on PTSD, probably we will be seeing that as well. But at the same time, right, I mean, our patients are very resilient, right? I'm inspired by them every day. And there's also concept of post-traumatic growth, right? So, many patients, and people can have PTSD symptoms at the same time, right? Really, meaning making, right? Or resilience, or other strength that they develop. So really studying the resilience and post-traumatic growth will become very important, right? I learn from my patients, again, every day. So I think really kind of capturing that, right? And studying that more would be very interesting. What about the cognitive dysfunction, right? Again, as people get older, we will be talking about it because that's what concerns any aging population. We do know, and some of the slides might be familiar to some of you from last year, right? But we do know that at baseline, right, people with CF obviously have the same intellectual functioning, but some of the cognitive domains might be affected a little bit more than others. And again, this is a study kind of on younger people with CF when compared to the patients with the bowel disease and healthy children, and they were tested for their memory and concentration. And both patients with CF and IBD did worse on attention and memory tasks as compared to healthy controls. And people with CF had even more distinct cognitive impairments as compared to IBD group as well. There were higher fluctuation rates, and they received lower scores in overall concentration performance, right? So concentration was a bit more impaired, and they were making more mistakes on memory tests as well. And maybe this is also kind of picking up on some. We know that our patients with CF do have high rates of ADHD as well, right? So we'll see kind of how that plays out. If we think about overall, just a baseline, why people with CF might be more predisposed to some of the cognitive dysfunction, well, living with chronic illness, right, and the multifactorial effects of the illness itself and the complications. CFTR function in the brain, we'll talk a little bit about that, later. We know that CFTR protein is expressed in the brains, right? We're still learning about its functions, but it might be related to some of what we're talking about. Neuroinflammation, we'll talk about that. Of course, inflammation is part of the response and pathophysiology in CF as well, but also neuroinflammation is part of the pathophysiology in many mental health conditions, including depression and ADHD, as well as the cognitive changes. Depression and anxiety can also worsen cognitive tests, right, and how people do cognitively. For example, in psychiatry, we'll talk about sometimes pseudo-dementia, right? And this is when somebody's so depressed that they're so cognitively impaired that they might look as if actually they have dementia. Sleep disruption, right? And we might be seeing more sleep problems with respect to sleep apnea, right? But that also affects the cognitive functioning, particular vitamin and other trace element deficiencies. Again, other comorbidities, including diabetes, right? But then again, we should be renal dysfunction. There might be worsening renal functioning with age, right? As a side effects, let's say, of the medications, or thyroid dysfunction. Again, the question is how the CFTR modulators, how they affect cognition. Do they not? But what's happening there? ADHD, substances. As our people grow older and they use more substances recreationally or otherwise, their brains are going to be exposed more and affected by that. Hypoxia, hypercapnia, of course, if the lung function is getting better, hopefully that's not going to be as much of a factor. Our patients post-transplant, right? So kind of post-transplant is an additional risk factor for cognitive dysfunction, right? The surgery itself, the delirium that often, comes up, that 40 to 50% of lung transplant recipients do develop delirium. In CF patients, it's actually less. It's 25 to 30, but still that can be a risk factor for kind of some of the worsening cognitive function. And then the medications that come post-transplant, immunosuppressants and steroids. And now we're getting, I guess, to the good things, right? Like, aging and neurodegenerative disorders. We've already seen few patients who have both CF, for example, and Alzheimer's disease, right? And we've had a patient, with CF and Parkinson's disease, right? So we're going to be seeing a combination of people who are taking care both of the CF and these neurodegenerative conditions, right? And those are complicated cases. How are we going to take care of those, right? This is a symptom of success, right? We will be seeing these very complicated patients. So I promise that we'll talk a little bit more about CFTR in the brain. So there is a strong and widespread neural expression of the CFTR gene in the human developing central nervous system. And there is a question that, there might be delay in frontal lobe maturation. I mean, it gets there, but there might be some delay in that. And again, does that somehow mediate ADHD development, right? Because the frontal lobes are affected, that might be the case. CFTR also seems to be involved in circadian rhythm regulation and sleep and wakefulness, right? So it can have some effects on sleep. So there's definitely question, right? How mutations impact, right, the cognition and overall brain functioning. So that might be something that is interesting for all of us. And then neuroinflammation. So inflammation, it mediates development of multiple psychiatric conditions. And for example, delirium that I mentioned earlier, right? It's this neuropsychiatric condition that happens when people are confused, they might not know where they are, they might be hallucinating. And it really is in response to medical illness, right? Something is medically happening or surgically, but a lot of it is actually mediated by the inflammation affecting the brain. Well, same thing happens in depression and ADHD, right? And again, even in dementias, right? So if our patients still have the pathogens, they colonize, they have exacerbation, there's inflammatory response that affects the brain. And really any insult or injury to the central nervous system can provoke this inflammatory response, such as, any infectious disease. And it can either promote or inhibit neurogenesis, right? Sort of the growth or the connections between the neurons. And it also depends on the chronicity of the symptoms, how often it happens, and the severity of the inflammation. And even though kind of, again, our patients are getting better, right? But the longer they live, right, with some of the pathogens and the inflammatory response, what response is it going to have on overall brain functioning is still a question. And then, in terms of the comorbidities, right, there was a study, for example, done looking at patients with CF and CFRD and healthy controls, and looking at some of the cognitive functions, testing. And as you can see, patients with CF and no diabetes as compared to healthy controls, for example, had 20% reduction in the processing speed. But if we add CF-related diabetes on top of that, there is even further reduction, right, in the processing speed. And it has to do with, not only, again, potentially the effects of the CFTR, protein expression in the brain or the chronic inflammation, but also the regulation of glucose and insulin. It can also affect, right, cognition. So kind of thinking about how, our patients live longer with the complications and how that is going to affect the aging brain should be very important for us. And this is actually a very recent article that was published in Lancet looking at dementias in general population. I think this is applicable for all of us, including our patients with CF, right? And it's interesting because the most recent report actually really, what is actually stating, right, that 50% of dementias can be potentially prevented. Right? So I'm like, okay, what can I do better here, right? So, and they kind of talked about these 14 risk factors, that if we manage them better, and many of them, of course, apply to people with CF, right? We can really actually prevent, right, or lessen the cognitive decline in the dementias. And what are they? Reduction of diabetes, right? Again, so really kind of the CFRD management is not only important for overall health, right? But for the brain. Manage cholesterol, which is going to come up more and more for our patients as they grow older. Minimizing hypertension. Stop smoking. I think a lot of it are not surprising, right? And sort of like, it's easy to list them, hard to do, but I think it's actually very important data, right? Reduce obesity. We know that obesity is sort of becoming, right, an issue for some of our patients. Reduce air pollution, prevent head injury, right? But it also might be about counseling our patients, right? I mean, I definitely have some patients who've had, right, kind of the thought process was, well, I'm not going to live that long, so I'm just going to do everything, right? And maybe even put themselves in more danger than they would otherwise. But maybe now, like, well, maybe you really should wear that helmet when you're riding a bike, right? But sort of that, maybe our counseling can change as well. Preventing or treating depression, right? Again, back to kind of my first few slides. Increasing physical activity, minimizing alcohol intake. Higher education or continued cognitive activity, right? Again, kind of how we'll counsel our patients is changing and their goals for themselves change. But really being cognitively stimulated is really important in preventing dementia. So thank you again for being here so early. Like right now, we're reducing our risk of dementia. So this is amazing, right? Preventing or addressing hearing loss, right? And we know that also might come up, right? Kind of more, and actually my patients kind of talks a little bit about that in the video, as a side effects of the treatments, right? So really recognizing and asking those questions. We'll make sure that PCP asks those questions, right? But somebody. Addressing visual loss and increasing social contact. Again, as our patients grow older, and maybe now their support systems, their parents are actually dying, right? Really making sure that they still have their caregiver support will be important. And the kind of existential questions that our patients are asking themselves and us are also changing, right? Who am I now, right? How do I cope with my changing body? I haven't even gotten to body image, right? But the body is changing, right? Due to due to modulators, right? And sort of that's, for some of our patients, maybe being thin, that was part of their identity, right? And now letting go of that, right? It's a big change. Who will look after me now? Now our patients are thinking about, oh my gosh, like actually my parents are gonna die before me, right? Like many of our patients have not thought that this is a possibility. So this is huge. Can I even express ambivalence and negative feelings knowing that others are not eligible for the treatment, right? So kind of the survivor's guilt. Can I trust this miracle drug to keep on working? That sense of uncertainty, it's not gone. People have a lot of uncertainty. Is this forever? What if I have side effects? What if it's not gonna work anymore? How will my disease progress now? I mean, we have the same questions and our patients are struggling with those questions. What have I missed out on with prior choices I was unable to make, right? How many of our patients are saying, oh my gosh, if I only knew that this drug would come, right? If I'd lived longer, I would have gone to college. I would have worked. I would have gotten married. Like I would have actually have taken care of myself, right? So there's a lot of that guilt. Kind of when we do therapy, a lot of those things come up. And what are my priorities and dreams now, right? So kind of a lot of existential, important questions. And then kind of additional, right, financial challenges, right, which we're going to be hearing about more, right? But oh my gosh, like I wish I actually was saving money, right? Like I have patients like, what am I actually going to live on? Like I did not plan to live this long. Parenthood, right? We had definitely a baby boom at Stanford Clinic, which is amazing, right? But again, well now that's like, I think there was, gosh, what did I just see? Well, I think it was like a big warning that actually like parenthood is not good for your mental health. So, but so that's going to be additional stressor, right? Longer careers, evolving bodies, as we kind of mentioned, as well as dying parents and caregivers, questioning early choices. For some patients, postponing transplant, right? I mean, hopefully, eventually, our patients will not need transplant. Definitely not a fun, choice if you can make one. But for some of them, we have delayed it, but they still might need it. But now they're going to be older with other complications, right? So that's going to be interesting, right, to see and actually how those patients will do with the transplant. And then loneliness, right, which is also like an epidemic that we all are facing. But as their families are now dying before them, right, kind of loneliness might be a bigger factor for some of our patients. So in conclusions, depression and anxiety continue to be present because they're chronic conditions, right? We will be thinking more about the cost of survivorship, how it applies to CF. I definitely invite you to think more about the PTSD symptoms and post-traumatic growth. There's this evolving existential psychosocial concerns. And then again, we will be seeing and hearing more and facing the cognitive challenges in our patients as they relate to CF, and also as they age with a chronic condition. And now we'll have some time for questions.
Thank you, Dr. Scher. Is there a question back there?
Absolutely. Thank you for pointing that out. Exactly, right? Like, absolutely. That's great, right? That's amazing, but also how different. Yeah, now we're defining children as caregivers. Fantastic. Any other comments or questions? Yeah, excellent questions. And if there's anybody else after my answer that wants to answer, please. I mean, there's definitely, I think, kind of in CF, right, what's been studied so far, obviously the CBT and the acceptance commitment therapies, right? In terms of the trauma, I think it's all good for us to have some basis, right, and how to approach and how to talk to our patients, and also teach I think part of the role of the mental health providers who are embedded in CF centers often to help our other colleagues, right, how to talk to our patients, how to ask those questions. I know that, I'm very lucky that, we have two social workers. We just had it changed. But one of them was actually doing like CF-CBT and ACT and trauma-informed care, providing that to our patients. I stole her to my psychiatry clinic. She was so amazing. Like Meg Dvorak, you guys know her? Mm-hmm. Now she's in psychiatry, like doing therapy full time. Also applied for CF-CBT. Like that's what she's doing now. But we have another therapist who's also going to be doing kind of therapy and trauma-informed care. And I also, partnered with several community providers. So I'm not trained in this, but I know that our community provider does EMDR, and we actually send a lot of CF patients to her as well, kind of to help with that. Mm-hmm. Thank you so much. That's great. Anybody else? Okay, and we'll also have time to kind of, have some sessions afterwards. Okay, well, thank you.
All right, so I'm going to be speaking. My topic is planning for the future and navigating life milestones. So I'm going to start off by sharing a story. So meet John. John is a patient who was diagnosed with cystic fibrosis at the age of 6 months. His early life was marked with daily treatments and many hospitalizations, and his parents were told that he wouldn't live past the age of 18. But today, John is 42. He's married, and he has 2 kids, and he's employed, working in his dream job as a high school teacher. So in his words, he tells us, aging with CF isn't just about surviving. It's about embracing life with all its ups and downs and still finding joy. So John's story is part of a new reality for people living with cystic fibrosis, one that is made possible by advances in CF care, as we've heard about today and over the course of this conference. But as our patients are living longer and they're facing new and unexpected challenges, our role in healthcare continues to evolve to help our patients live their best lives. Now, I want to be clear, I'm not here to be the only expert in the room. I'm here to share some insights because I know that many of you are specialists in your field and you're the ones that are making real strides in your clinics and in your settings. My goal is to start having some conversations with everyone here, offer some perspectives, and then share stories and challenges that patients are experiencing so that we can continue to work together and figure out how we can improve care for our patients. My discussion today will be more about the practical aspects of how we as a community can support our patients living with cystic fibrosis. And so I don't have all the answers, but I hope this presentation will be a platform to share and exchange some ideas. This is the disclaimer from the conference, and I have no relationships to disclose. My objectives are to talk a little bit more about the unique challenges of aging with CF, talk about some practical strategies about promoting overall well-being, and to develop an approach and perhaps find a little bit of a toolkit at the end. So this is how I intend to use our time together. I'll just talk through this. So during this presentation, we're going to briefly touch on the evolution of CF care as life expectancy improves and discuss how we can support individuals achieve their key life milestones of their choosing, and discuss how the importance of starting conversations about financial planning and health management are really key. We'll discuss how to foster and maintain independence, autonomy, quality of life, and emotional well-being, especially as our patients take on these new roles in managing their health and in their lives. And then I'll wrap up at the end by mapping out a toolkit which has conversational starting places. It's not a beginning and an end, but it's really just about starting and having some practical strategies to help us all think about how we can empower our patients as they grow older, and then give them the tools and give us the tools to help navigate this new and exciting phase of life. And you'll notice over the course of the presentation, I'll also continue to share some stories that have been anonymized, but really just for pieces of relevant information that are going to highlight some of the messages that I'm going to pass across. As we all know, we are in a new era. We're talking about something that seemed unimaginable, this idea of aging with cystic fibrosis. So we know with the advancements of CF care and recent developments of highly effective modulator therapy, patients are living longer and healthier lives. But with this transformation comes evolving challenges, opportunities, and decisions that require thought and planning. This journey, as we know, is not just about managing the medical aspects of the disease, it's about providing care which address the whole person, their mental and emotional health, social connections, as well as their goals and their dreams. It's about empowering our individuals to live their lives to the fullest, regardless of the challenges that they face, sometimes despite the challenges that they face. And we know that our patients are, experiencing very unique challenges, considering once upon a time they were told that their life expectancy was very short. And even though it was improving, it was still short. Now things have really changed in the last little while. And while the provider role, as you've heard before, is very essential and continues to be essential, we know that the focus has shifted, or will be shifting, and is shifting to more of a holistic and individualized care. And so it's this power of collaborative and multidisciplinary care approaches that we need to focus on, and the need for proactive planning to ensure our patients, again, continue to have that quality of life that they want. So let's just take a moment to think back. Think about how once upon a time people could not imagine what the future of cars would look like. And all I'm trying to show here is that similarly, our CF patients and their families didn't expect to hit traditional milestones. Many parents didn't plan financially for their child's education, and young people with CF weren't encouraged to dream beyond a certain age. The main focus was survival, getting through each day, managing symptoms, and hoping for a medical breakthrough. But as we all know, today that landscape has shifted. We now find ourselves at a crossroads where CF patients are needing to plan for a future that they never expected, from surviving to thriving. And while this is incredibly exciting, it also brings up some important questions on that road to thriving and how our teams can help our patients reach their goals. So as we move beyond just handling health issues, the focus on survival, our teams are beginning to have transformative conversations with our patients and their families, because now we're looking ahead and we're looking at a future filled with milestones that many in the CF community are experiencing for the first time. So another patient, take the story of Julie. Julie, as she was growing up, her family didn't expect her to live past her teenage years. And so they encouraged her to focus on life, just enjoy, have fun. And so she didn't plan for college, and no one expected her to actually be able to be well enough to attend. But Julie's now 43. Julie is not only a mom, but she's back in school, and she's pursuing a second degree. Julie's story shows us that assumptions of the past can affect our expectations of the future. And she's an example of how our patients are accepting change and learning how to shift and adapt to their new circumstances. Now, the shift is particularly relevant for many of our young people with cystic fibrosis because now higher education is now both realistic and attainable. And while balancing the demands of academic work, we know that health can still present a challenge, but our patients are now telling us that they're finding it more manageable because health expectations with associated medical treatments have become slightly more predictable. Our role is to support our patients through this transition, navigating the logistical and emotional aspects of living away from home, managing their treatment schedules, and accessing healthcare wherever they are, perhaps on campus or at a clinic closer to them. This may also include helping our patients think about and prepare for the financial realities of higher education, including looking at scholarship opportunities or applying for financial aid, or helping them budget when it talks about living expenses. And then further along, as our patients graduate and embark on their careers, planning around this journey becomes yet another critical milestone. Many of our patients are pursuing ambitious careers and achieving amazing professional successes. However, they also face unique challenges like managing a demanding job and dealing with exacerbations that we know are going to happen just by the diagnosis of cystic fibrosis. So this might mean making strategic decisions about a career path that supports both their professional aspirations and their health and allows them to have a sustainable work-life balance, which allows for relevant disability accommodations if needed. Similarly, as our patients move into young adulthood and beyond, many are encountering new and exciting opportunities, whether it's pursuing relationships, getting married, starting families, or exploring different paths that align with their personal goals and their lifestyles. While some may have already begun to push for these experiences, we're noticing that people are choosing these opportunities more frequently. And for those considering parenthood, as we've talked about, this is a very challenging time. It includes the challenges of pregnancy itself, perhaps having conversations about adoption or surrogacy, as well as the actual physical demands of parenting with cystic fibrosis. And so in these circumstances, we know that our patients are unlikely to only think about their own health, but they're also going to think about their children's future and budgeting for those expenses and saving for their education, or pulling together a support team for when their physical health may become a higher priority. And then we might be called upon to help our patients create financial plans. Again, whether we become those experts or we find resources that we link up our patients to have these conversations that help to meet both their immediate needs and their long-term goals. But in order to make these things happen, financial planning requires more than just a passing conversation. CF patients will need to shift their mindset, including financial security. And while we know this is true for everyone, the added burden of medical costs, potential disability, and fluctuating health can make financial planning more complex. Here's another story. It's the story of Sarah. When she was in her 20s, she didn't think much of her treatments, of her retirement, because it just seemed so far away. She enjoyed her life, she lived in the moment, and anything she made, again, she spent. But now she's 50, and she's facing the reality that she could live much longer than she ever imagined. She tells us a lot about feelings of regret, about the things that she didn't do and that she didn't prepare for, and now has become a big advocate to encourage our younger patients to think about the future. And so we try and connect her to people that may have questions about what the future might look like when we think about financial planning. This brings us to health management. And I know we've heard a little bit about this earlier today from my other colleagues, but it's talking a little bit about, again, CF specialists are going to continue to play a key role, but it's equally essential for patients to be proactive with their healthcare and to collaborate with their primary care physicians to address non-CF health-related issues. For example, just to touch on conditions that are prominent that are aging, like diabetes and osteoporosis or cardiovascular disease or mobility challenges. Many of these things can benefit from earlier intervention, which can significantly enhance a patient's quality of life. So for example, there's a patient, Peter. Peter is now in his 60s. He discovered he had osteoporosis, but it was found by a routine screening by his family doctor. Now, this condition could have easily gone unnoticed until symptoms showed up in our CF centers. But with this integrated approach to care, he was able to make necessary lifestyle changes, able to take the treatments that he needed before his condition worsened. In addition, our patients are expecting to be active participants in their healthcare. They're seeking continued patient-centered care and involvement in all of their treatment plans. Another example, Wendy. Wendy is 35 years old. She's a graphic designer who loves her demanding job. But she tells us that sticking to a strict treatment plan was really getting in the way of her ability to do her work. And so talking it over with her team, she was able to adjust her routine to better suit her life. And so it's this kind of flexibility that helped her manage her health, looking at it from the point of view of what mattered to her. And so this is what the trend is. It's about this trend towards autonomy. And it's pretty consistent that we're hearing across the board. The patients want to have a say in their healthcare, and they want to tailor their treatments to fit their lives, not the other way around. Likewise, with longer life expectancy, quality of life also becomes further prioritized. This means we need to co-create comprehensive care plans, and with patients as partners, focus on balance, providing an opportunity to incorporate those holistic viewpoints that allows for the integration of physical, mental, and emotional health. While healthcare providers may define quality of life based on lung health or fewer exacerbations or perhaps greater health stability, it's important to see that if teams are able to embrace a patient's perspective, not that we're not doing it now, but more of this in the future, they may be able to see that quality of life from this new lens. And then they may be better equipped to understand and advise to the unique needs of their aging patient. So this might mean that the roles may shift in CF teams to include health professionals that typically weren't part of your teams, like geriatricians or cardiologists or gynecologists that specialize in menopause. You may also lean on your physios and RDs in different kind of ways to highlight long-term health and function. Patients may also want to include alternative medicine experts as part of their health circle. One of my examples here is a patient, Aaron. Aaron is a person who is in his late 30s and he struggled with depression. As his health began to stabilize, and I know that Lisa mentioned this earlier, is that even though he was well, now he started to feel extremely lost, not sure what to do, where to go. He found his support through psychotherapy and mindfulness practices, but also utilized herbal treatments and acupuncture that helped him stabilize and regain a sense of purpose. His story shows that being receptive and open to the patient's choices can allow our CF teams to create more meaningful conversations around treatment plans and shared goals. Conversely, aging with cystic fibrosis also brings new struggles. Many patients who never expected to live into childhood find themselves confronted with regrets about past choices, like whether not taking care of their health or not pursuing an education or maybe neglecting to plan for the future. Another patient, Tony. Tony's 55 years old, and he openly admits that in his 20s, he didn't take his treatment seriously. He skipped his medication, he was non-adherent to his care plan, and he burned bridges in most of the relationships that he had. And now he finds himself isolated and alone and faces many more serious health complications that he can now see could have been avoided. While he started to make some changes and is hopeful in these steps, he knows that his past choices have impacted him and will likely impact him for his immediate future. So in addition, as patients began to play new roles, as they move from being cared for by their families to having families of their own, to again shifting to now care for aging parents. These new roles present particular challenges for CF patients who must learn to navigate aging, not just for themselves, but for their immediate and extended families as well. And the dynamics of the support system also change, as mentioned before, how parents and partners and friends who they previously relied on are no longer available quite the same way. And so as a result of these competing issues, patients may voice declining some types of care because it helps them balance their life philosophy. It helps them encourage a life that's important to them, that is connected to their needs and their values. We have to always remember, as mentioned in Lisa's talk, that managing a chronic condition for decades can take an emotional toll, and patients need support systems, and it's critical that we address their mental health and emotional needs as they arise and connect them to the appropriate resources. So aging gracefully also means building resilience and keeping a positive mindset. These are important as they help individuals focus on what they can control and allows them to face challenges with optimism. I found this great quote by Ed Batista, who's an executive coach in California, and it says, it's all about resilience, and it talks about how truly resilient materials are sufficiently elastic to allow them to absorb a blow, deform under pressure, and return to normal after a brief interval. I really like this description. I felt like this is something that we're trying to teach our patients on a regular basis. And in addition, acceptance and adaptation speak to embracing our patients' values and goals and teach us skills to flexibly pursue what's important despite obstacles that they may face. Another patient, Laura, she's 53 years old, and she's had to face the fact that she's outlived her original prognosis. She says that she spent so much of her life thinking that she wouldn't live to see past her 30th birthday. But now she's 53 and she's having to reimagine what her future would look like. And so as our patients get older, grace may include finding a sense of purpose and fulfillment. And this might be by finding what brings our patients joy and what lifts their spirits. And perhaps encouraging our patients to be open to new experiences and challenges challenging them to potentially have some opportunities for new growth and new rewards. And so in order to do this, I've pulled together some observations and ideas from my clinical experience and from the literature on how we can offer care, as well as practical, again, conversation starting places to help guide teams in future conversations. So to understand and appreciate the changing needs of our patients, we need to recognize the power of collaborative, team-based approach as our patients age and their needs become more complex. Coordinated care can truly make a difference. However, it's not just about teamwork. It's about seamlessly integrating our efforts to create a unified plan. This means regular communication between providers, shared decision-making with our patients, and a clear understanding of each team member's role. Because by coordinating our care, we can avoid fragmentation and to ensure that very little, if nothing, falls between the cracks. For example, I have another patient, Sam. Sam's 65 years old, and he is 28 years post-lung transplant. He highlights the confusion of managing multiple care teams as his health has deteriorated over the years, and this need for clarity on each team's responsibilities. Teaching our patients how to navigate, how to access what they need within their healthcare system is invaluable. And while CF health management is a key ingredient of living well with CF, we have learned that it's just one part of the equation. Encouraging our patients to embrace a healthy lifestyle and including regular health screenings, balanced nutrition, and exercise is equally valuable. Because we've learned that health encompasses more than physical health, and it also involves our mental and emotional well-being. And self-advocacy empowers our patients to manage their care effectively and ensures their needs are met. We can also continue to encourage strong, supportive connections and highlight how vital it is for emotional well-being. These relationships provide the support and care needed to persevere through challenging times. And looking ahead and planning for the future requires conversations about aging with CF, discussions around financial planning, power of attorneys, education, family planning, just to name a few. And to effectively support our patients, we may also need to create a range of responsive resources tailored to these unique needs. And these are ideas that are not currently present in my center, but things that we're talking about, but things like establishing support groups, which can foster community and connection, and using our social media options to enhance outreach, launching podcasts potentially focused on aging with cystic fibrosis. And maybe it'll allow opportunities for patients to hear about expert insights and also maybe create a place for patients to share their personal stories. Additionally, developing a comprehensive resource hub on our website, potentially offering educational workshops or interactive webinars. All of these opportunities can empower our patients with essential information. Now, if we step outside of CF, there may even be, outside of our organizations, places that focus on chronic illness that can help support our resource network that our patients can utilize. And so with this toolkit, the goal is to start small and to build on these discussions from visit to visit, and to take this starting toolkit and further build one that is more comprehensive for you and your clinic. And so in conclusion, living longer with cystic fibrosis is a beautiful journey that will require more than just medical care. It demands a holistic approach that includes the ability to chase dreams. And by supporting our patients and staying connected to their sense of purpose and helping them to remain open to new experiences and planning for the future, we can help our patients persevere. I have one final story, and the story is of James. James is a 53-year-old patient whose family was once told that he wouldn't live beyond his 10th birthday. But like many of the people you've heard about today, James is not only surviving, but thriving as he's watched his own children and now grandchildren grow older. His story tells us that with the right planning and mindset, anything is possible. And that's it. Thank you very much. Does anybody have any questions?
All right. And our last presentation is actually going to be a recorded presentation from one of our patients, in our center, who is actually, active and totally okay with kind of being disclosed, and somebody who is actually like a very talented drummer as well. So, and I tried to look up like drumming in CF and actually have not found anything, but you will see kind of his blog at the end, which I think is fascinating. And let's hear his story. He just will share, what he has to say. And I mean, kind of as I was, listening to our presentations, and I would invite you, think about, hopefully we, three of us, the providers, have hit on some of the themes that Alex is sharing. But maybe also pay attention to that. Like, did we catch it all? Is there something else, right? Because again, like we're learning from our patients. Disclosure, I was not supposed to be on camera this day. I'm like, I'm just gonna record him. And he's like, can you interview me? And I'm like, I'm in my black hoodie. So very, very different look. So forgive me, and just close your eyes when it's like my face. I'm gonna like totally look away, so yeah. And I hope this works. Yeah, exactly, right? I'm like, that's great, okay.
Hi, Alex. Very nice.
Hi.
Hi. Thank you so much for joining me today and for being here. So if you can we can start with you just telling us a little bit about who you are and where you are in life. I'll ask you some questions about your experience.
Yeah, so my name is Alex Jenkins. I live in Sacramento, California. I will be 50 years old in November. I have cystic fibrosis. I also have CFRD and some other complications that come along with getting old or getting older with CF. I actually play the drums for a living, something that's very meaningful to me. I teach a lot. I also perform a lot. Playing the drums and being involved with music from a young age, I think is part of the secret, or maybe not so much a secret, to the longevity that I've had. It's very fulfilling to me, and it's very important to me. I also am married, and I have 3 stepchildren that are all adults. And in fact, our youngest has a 6-year-old. So I'm actually a grandfather, if you can believe that. Pretty amazing. Never thought I would ever be in that situation. When I was born in 1974, I believe that the people with CF, kids with CF, were really living past their teenage years. And it's just incredible that, all the progress that's been made in the last 50 years is absolutely amazing. I think about it every day and am constantly blown away by it, actually.
Yeah, I appreciate you being here, and congratulations on all of those achievements.
Yeah.
Remarkable. And it sounds like, as I know about you, drumming, right, and being in drama has been such a big part of your journey and what has helped you to cope, right, and be strong and creative. Tell me more about sort of, this section is on growing gracefully, right, like graceful aging, but I can't even say that when I look at you, right, with cystic fibrosis. So tell me about, again, of some of the challenges, or as you grow older with CF, what are some unique challenges that you feel you have faced?
Excuse me, maybe the biggest one is, how to support myself. Having chronic illness can be extremely expensive at times. Actually, not at times, all the time. We're always challenged by, healthcare, trying to make sure we have healthcare, being able to make money and support, all the various needs that we have when we have CF. I'm sure it's no secret that we eat a lot of food to maintain our body weight, and that is expensive, and it gets more expensive all the time. I'm very fortunate that, I am able to support myself and make a living doing what I do. I've worked really hard at it my whole life. But also, there's other things that have come along that have been really hard. A couple years ago, I found out that I have vestibular damage from ototoxicity due to IV antibiotics. And from what I learned, that is starting to happen more and more with people as they get older with CF. That was kind of a big life-changing moment for me because it really impacted my quality of life. I've since been able to, adjust what I do so that it doesn't affect me that much. But it was, kind of hard to go through in the beginning. I also have osteoporosis that's very challenging at times, many exacerbations and hospitalizations. I even had a lobectomy at one point when I was 21 years old that saved my life. So going back to your question, I have really had to strike this balance between the realities of everyday life and just trying to support myself, balance that with, all the daily care that I require, doing my treatments, making sure that I'm eating healthy and high calorie meals, driving from Sacramento down to Stanford for my appointments, which, is a whole day's travel there and back, and then also kind of letting myself off the hook if I get sick and have to go to the hospital, or if I have to spend extra time doing treatments. I've had to work really hard over the years to kind of let myself off the hook and be okay with that, because I am very driven in what I do, and I try to be as successful as I can be. And, but the reality is that us who have cystic fibrosis don't fall into the same category as most people. We have maybe a different trajectory and a different focus. And that focus being, that we have to preserve our lung function for as long as possible. And at the same time, just dealing with the everyday stressors of life. Yeah, I wish I could say it gets easier as you get older. That's actually, I don't think, the case.
It doesn't, yeah. So it sounds like you're kind of describing, the expected sort of complications of cystic fibrosis, then the complications of treatments, right? Something less expected, right? And of course, the financial requirements, the time requirements, the mental health requirements, the full time, this multifactorial effort.
Yeah, absolutely.
What has helped you sort of to cope with all of this, right? What keeps driving you forward, inspiring you? Kind of what tools have you been using or you have developed over these years?
Yeah, so again, going back to, when I was born in the 70s, mental health wasn't a focus at all. I mean, I think most CF centers, if there were even CF centers back then, I'm sure there were, not as many as there are now. But I think most CF doctors, were just trying to get these kids, to live past teenage years. And so there really wasn't any mental health focus. I didn't really start working on my mental health till I was in my adult years. And that's one thing that I wish I had had the opportunity to work on when I was younger. I wasn't even actually approached by my doctors and even asked if my mental health was even an issue. I know that's different now, thank goodness. I know there's lots of focus on that. And I've definitely benefited from, working with a doctor, working with doctors who are very good at what they do when it comes to mental health. And having that be a focus, I think, has really helped my overall health and quality of living.
Great. Yes, I'm of course I'm biased, but I'm so glad that is being addressed more and more right now. But it also sounds like that, you bring your own, right? Also individual strengths, right? For example, the drumming, right? And the passion that you have and the relationship that you have in your life. So I wonder how much you think that also has helped you to cope and keep getting older and older with CF.
Sure. Yeah, well, I had really supportive parents. And what's incredible, just as a side note, I actually have outlived both my parents, which, is an amazing thing. I mean, obviously I miss them. I wish they were still around, but no one thought or knew that would ever be the case. But going back to your question, I had really supportive parents who, when I started getting interested in music and drumming, they right away, had me taking lessons from a pretty young age, and tolerated what I'm sure is years and years of just noise as I learned to express myself on the drums. And the people that I know who have cystic fibrosis, most of them have some sort of outlet in their life that they're very, very passionate about, whether they make a living at it or it's just, more of something they use to help cope with everything that we have to go through. Occasionally I have the opportunity to talk to younger people with CF, and that's something that I always bring up is that, find something that you're passionate about. Again, you don't have to be making money at it or try to get rich from it. That's not the point. The point is to find something that you're passionate about and something that brings you joy, because we deal with so much that is difficult and scary and emotional. And if we have something that we're also, very passionate about, that is a very important piece of the puzzle for overall health.
Thank you for sharing that. So it sounds like really the relationships, right, and this outlet, this passion that drives you, those have been such important contributors to your overall health and well-being.
Absolutely, yeah.
Well, tell me, what advice would you give us, the providers, right? The pulmonologists, the nurse practitioners, the social workers, the psychiatrists, psychologists, everybody, right? The CF team that is working with patients with cystic fibrosis who are getting older and older and older, right? What advice, what do you want us to keep in mind?
Well, I would love some CF center to do a study on playing the drums and cystic fibrosis, because I'm not joking. Playing the drums is some of the best airway clearance. Like I probably get more out of that than I get with my best treatment. And that's always been the case. It's one of the things that it maintains my mental health, it maintains my physical health, it maintains my spiritual health. And also, just to go back to what I said about mental health, I just wish I had been exposed to that at a younger age. When I was a teenager, it was really hard for me to accept the fact that, I had a chronic illness, which I'm sure is a shocker to everybody, teenage years, probably the hardest years that, we'll face. I think that, as far as people in the mental health field go, one of the things that is really important, and one of the things that I've benefited from hugely, is doctors and counselors who seek to understand rather than judge, right? Because I've had some CF friends who feel like one of the counselors they may have gone to is more about judging who they are and what they should be doing rather than seeking to understand why they are or not doing something that they should be. And I think that's probably obvious to everyone who's watching this that should be the case, but unfortunately, I don't think it always is the case. And that, that we can extend that out to our families too. Like with my wife, she's such a rock in my life. And one of the, mantras that we have between us is, we should seek to understand rather than be quick to judge. Not only mental health professionals, but even just CF doctors in general, I always appreciate a doctor who is really willing to listen. I'm really lucky that I have doctors that do that. They really listen. They really listen to what's going on before jumping in and trying to make things that, might be hard for people with CF to hear.
So it sounds like kind of really listening to you as the whole person, as the whole individual, right? Of course, from the mental providers, but I'm sure from all other providers, it sounds like that's really important now, before, and going forward. Seeing you and hearing you as the whole person.
Yeah, more of like, it's more of a holistic approach. I'm really happy with the doctors I have right now. I think they do a good job at that. Any patient who feels like they're not in that position, you need to advocate for yourself. That's something that my mom taught me from a young age. Is she really taught me how to advocate and how to stand up for what it is I need. I think doctors are so stressed and overworked in general. It's easy for patients to fall through the cracks, but got to stand up for what it is you need.
And I'm sure that's also been one of the sort of this magical ingredients, right, in your overall success, right? The advocacy, right? But obviously you've had a great support system and your parents have taught you how to advocate and you have been advocating for yourself. Well, Alex, thank you so much for sharing with us your story and your wisdom. Really appreciate you being here. Any last kind of parting words?
I guess just to say, I hope that, people that hear this, get something out of it. And I try to be as involved as I can with education and letting, sharing my story, whether it's on social media or through my website. I'm always available to answer questions or share more of my life for anyone that's interested.
And Alex couldn't be with us here today. He's in California and probably still sleeping, which is why we didn't invite him to come. That'd be nicer for him.
Yeah, just kind of few clarifications, right? So I mean, how many of you have seen kind of some of the, and we didn't, like you, for example, you did not listen to this before, right?
No.
But so how many of you have seen kind of some of the points that all of us have raised that Alex has brought up, right? I was like, oh, right, like holistic approach. Self-advocacy, right? But then also those, osteoporosis, right? And he has vestibular dysfunction, which actually took a while to diagnose, right? So sort of like his sense, right? It's kind of, sort of like the sense of like, right? His coordination of his body is off due to some of the antibiotics that he has had to take. And he's a drummer, right? So he has to, like, he needs to use all of his 4 extremities. So it was actually a process of grief for him when he realized what is happening. It did take a while to diagnose, and he did bring it up to the CF clinicians, but they were just starting to actually see and appreciate this, right? And I don't know if he had a PCP provider, it would have actually been done sooner, right? But then there was a sense of grief and realizing, oh wow, now I have this complication related to the treatment, right? And how this affects his sort of overall quality of life and his drumming, but he's been able to adjust. But it's interesting also to be working through kind of new, even mental health challenges, right? And this new, kind of that now we're seeing, so. All right. Well, what questions, comments, conversations, we have 20 minutes left or so, kind of definitely opening up to all of you guys. Or anything that kind of watching the video, kind of anything, any thoughts, kind of anything that, you want to share based on the video. If Alex were here, if there's anything that you would want to ask him.
So, their child to become independent.
Yeah, absolutely. Thank you for sharing that important perspective, kind of this ongoing transitioning, right? So absolutely. So I'm embedded in adult center, right? So we kind of definitely see that shift in roles and reestablishing boundaries and supporting the parents and right, but kind of helping our adults to become adults, absolutely. And it's ongoing into like 30s and yeah. No? Okay.
I was just going to piggyback on that.
No, absolutely. I mean, I have like, personally, my teenagers like growing up and I'm actually identifying more now with the parents. I'm like, but I totally understand, right? It's sort of like the perspectives is shifting, right? It's interesting. You're like, well, yes, yeah.
I'm reading a book right now. It might be helpful to see things when you do it.
I think traditionally, these conversations have happened when there's a need. So I think it's really about separating the need and the conversation, that these are things that are just natural conversations that we have as we age. Thinking about the future, planning a will, having a power of attorney in the event that these are needed. But it's separating it from a health change. And I think that's the shift that our clinics are in now, because we haven't done that before.
Yeah, at Stanford Clinic, so now we are doing this, and I'm actually not part of it, but our social worker and our nurse practitioners, they have now yearly meetings, advanced care planning, where they go through this. And again, it's normalizing this. It's sort of divorced from where you are, but it's sort of like, these are regular conversations that truly all of us should be having, right? And you do have a chronic condition, right? So it does make sense, right? But just embedding it as part of the care. And yes, it's additional burden, like another thing to do, but it's also, very meaningful, definitely discussions, just kind of normalizing it. Yeah. Well, I'm just kind of listening to ourselves and just thinking through, right? I mean, it sounds like really, the CF centers, right? All of us should be partnering more, like finding out the PCPs, as has been mentioned, right? But also thinking about career planning, right? Financial planning. If there's somebody in the community, we can have this like appointed person, right? And we can refer our patients to. Because I also, I know I have a patient who, has had a career that sort of made sense for her based on expected survival. And now, obviously survival is much greater, and she's really struggling to kind of rebrand herself and to think where to go next, right? So, I mean, for her, I would love for her to meet with a career coach. So if CF Foundation has, kind of those resources, that would be amazing. So, yeah. Mm-hmm. Yeah, thank you. And I also know that there was a poster last, some, myself and some few other people actually writing right now a review on potentially kind of mental health in lung transplant in people with CF. And there was a poster that was forwarded to me from last year that I didn't see it yet published yet, but it's actually very interesting. It actually highlights that the outcomes in people with CF post-lung transplant, they might be actually different as compared to years ago, right? Because people with CF have had the longest survival after lung transplant. And the concern is it actually might be changing now, that we might not, in terms of that older people might be now getting transplanted, right? The mutations that people come in with, right, are different. They might be older, they might be more complicated. So also, and that of course will add to the mental health and psychosocial complexity as well. Yeah. Okay. All right. Well, thank you everybody so much for coming, for asking questions and contributing.